Hello and welcome to today's live show. I am very excited to be back after a few weeks with my precious newborn baby, and I just want to welcome Dr. Robyn, who has been my amazing support from behind the scenes. Hello Rob, thank you for today.
Hi Chelsea, and I'm so excited to see your little baby almost in real life. I can reach out and really touch her.
Yes, she's here in between feeds and sleeping. And today we're going to be discussing something that of course is very close to our hearts, and it is Dr. Robyn's Isation syndrome. Sorry, Rob. And today we're going to be discussing part 2 of that, which is the institutionalisation of pregnancy, labour and birth. So mainly within the hospital, but generally within registering as a pregnant woman within the system, how you can feel institutionalised and how you can sometimes even become institutionalised within that process. So Rob, I guess my first question, Dr. Robyn, is the Isation syndrome. What is it for others that haven't heard of it before, and why is it so important that we shine a light on that in these times?
Well, like this, it came about with me looking at what was happening over my midwifery experience over 50 years. Why and what and all the questions that go on in my head. And I have to ask questions all the time. It's almost like I've got a problem because
well, thank goodness you do.
Because it seems to me that we've gone beyond any reasonable respect for women, right? We have changed so dramatically over the last 50 years. And it really worries me that we can do these things that are happening to women in the institution. And the women are telling their stories, and that's how we're getting that feedback from them. They are providing feedback. They're providing feedback live, and they speak with me live. Sometimes it's videoed, and it's never used unless they provide their written consent, but they have a copy of that link of that video so they can review it themselves anyway and go back on it. But the stories are so worrying for an old midwife like me, who really didn't experience a lot of the things with women that are happening now. So the women are also talking to the media, and that's happened here in Australia. The women all over the world are talking with each other, which is quite interesting too. In the UK, the midwives are marching because they're fed up with what's happening as well. There's so many things going on that should not be happening with women. So the Isation syndrome is really about hospitalisation, medicalisation, institutionalisation, policyisation. Policies are not legal, and they're not meant for every woman to follow the same policy. The other things that are politicalisation, where politicians are interfering in professional life, and that should never happen. Politicians have no right to interfere in the professional's life. It's our responsibility to be complementary with each other for the benefit of the woman, and to include her in that as well, never to exclude her. Total respect for the woman and where she wants to be and what her knowledge is about herself. And of course, we are there as a perfect team most of the time, not all of the time, most of the time when it's needed for the benefit of the mother and her baby. So again, we as professionals also need to be reviewing what we're doing and how we're going about our practices. And we need to, what I would refer to, stop the pedestal effect, where medicine thinks they're in control, and they are not. They have to respect the woman too. Now, that's not every medical practitioner, as we know, but there's a lot of it going on. And women's bodies are being handled in a way that should never, ever happen. Never. Hands off unless it's absolutely necessary. That's her body, her baby, and she knows what's going on. And if we stop and listen and observe quietly and calmly, then we can see what's going on. We can hear what's happening, and we do not have to do all the things that we do to these beautiful women. And we do not have to fill them up with opioids that affect their baby. Is that okay?
And I think the most important key point there is that women are making decisions or being almost coerced into decision making where they don't fully understand the pros and cons and reasons behind why that decision has been suggested, even initially as well. And like you say, hands off. I saw a really interesting quote recently that said, a woman knows when to ovulate, a woman knows when to be fertile, and a woman grows her baby in her body, she will know how to birth her baby. And it is very true when left to their own devices, unless a woman requests otherwise. A lot of women that are choosing natural or physiological births are being sidetracked from their wishes because of policies and procedures and medicalization, like we discussed in our last live in part 1. So it all happens every day. We see it within the club. You see it more so than anyone. I hear it through stories. My friends' experiences are quite similar as well. So I just want to talk about one of the main interferences, one of the main interventions, and you talk about the cascade of interventions quite a lot within the Thompson method, is induction. So that can be the very first. I mean, there can also be ones that come before that, but that can usually be the first intervention. And my research shows, which I'll pop below for those watching, my research show that 2 in 5 in births that begin with induction end in a C-section. Now, many women choose to have a C-section. Many women have made an informed decision to go for that route, which is great. Intervention and medicine is necessary sometimes, it absolutely is. But a lot of the time women aren't being informed of the risk of induction and the link to C-section, which always shocks me really, because it's quite high. 2 in 5 births, I think Robyn will agree, that's quite high to go into something, especially when I mean, it annoys me really, because a lot of women are being recommended a form of induction without actually knowing it.
That's right, absolutely right.
Like the sweep or the gel. And they're actually being told, some of them are even being told that the sweep, the gel, the balloon, which is actually still induction, but just a less invasive type, they're actually being told that this will help get things started, and you'll be more likely to have your natural birth if you take this route. So what are your thoughts on that, Dr. Robyn?
Well, my thoughts are way different to that, because I think we are interfering with women's bodies, their gestational age, and every gestational age is unique to the genetic background, and we have to think about what we're doing and why we are doing it. Why are we wanting to shorten gestational backgrounds when we're hearing so many stories from women that are now beginning to go to 40 weeks, 41 weeks, and on the average of my home birth practice, around 1,000 women, it was about 41.5 weeks on the average. Of course, we're looking after them during that time, and they're talking with us, and we're observing and listening and making sure that everything is progressing in the way that it is healthy. But there are so many ways now of wanting to intervene in the pregnancy, and that concerns me immensely, because why do we want to shorten a baby's gestation when they haven't reached maturity? You know, they're much better.
I've learned something myself recently, which is the gestational date is an estimate date, not an end date.
It's an estimated date, and it's different for every single woman. Yes. And we cannot go by plus so many days.
No.
It's crazy. It is not that accurate. And I have to say loudly, quietly, loudly, that ultrasound is not accurate, and it's being used as a tool which is creating fear and coercion. And one example I'll give you right now, that in a few weeks ago, I had a woman telling me that she was told from her ultrasound that her baby was going to be a dwarf. That was the language she used. So it turned out she was desperate through her pregnancy, you know, devastated. When it came to the birth of her baby was a normal, healthy term baby, no problems. So we have to stop relying on all the technology and come back to the skills that midwives and obstetricians had in the years gone by, and where they communicated with the woman and where they talked with the midwife, and we were all part of a beautiful team with the local GPs as well. And there was this lovely communication system that went on, and we looked after each other as well as we together.
There was a more of a multi-agency.
Well, we were complementary for the woman, and we were complementary in our skills, because we know that our skills vary from what's needed at any one point in time.
So I should imagine then that over the last 50 years, gaining all that wonderful experience and working beside those wonderful women, I should imagine you have seen a dramatic change in the care of that multi-agency that you're mentioning. So what is one key thing? I mean, I'm sure there's lots, but what is one key thing that stands out for you that you notice mostly between the care that's gone from community-led, I imagine, to now being hospital-led?
Yes, well, that was to suit the politicians in Australia, and they decided that all women would go to the hospital to save money. And so it happened in Victoria, and it happened with the health minister at the time, and the person in charge in Victoria at the time. I won't mention names now. Around about 2009, and then all healthy women were being transferred out of community bases close to home, close to family, close to friends, and they were being moved into illness model institutions. And now we are taking up so many beds of people who could use those beds for illness. They are genuinely beds for illness. Midwifery units have grown out of proportion. But guess what? They're closing down hospitals in the outer regions now altogether, and the same thing's happening. Women are having to travel miles to get to help. So I'm hoping that in my lifetime that I can see a turnaround again, where women will be choosing who they want to birth with and where they want to birth, and there'll be choices across the board. And I think that's very, very, very important to start to build on, and I do think women are beginning to realise that around the world. There's certainly more emphasis on having a baby at home now than there was, 12
absolutely.
months.
I think that is one thing that we can thank the craziness of the pandemic for, is that home birth seems to be on the rise. And here in the UK, our NHS trusts, our hospitals are releasing monthly infographics from their maternity departments, and they are detailing the percentage of births that are vaginal, that are C-section, and where they are. So which part of the hospital are they in? The labour ward, which has a huge link to a more increased interventions, so probably around 70% from the infographics that I've been seeing. And then you have the midwifery-led unit, which is usually less than 5%. So not all hospitals have access to midwife-led care or a birth unit. Depends on where you are, what they're called. But it's very low, the amount of women in my area.
And excuse me for moving around, but I just need to...
No, go ahead.
And
it is shocking, really, because the intervention rates are much, much lower at home. But even so, at a midwife-led unit, they're much, much lower.
Yes, but even at home, they're much less.
Oh, and yeah, they're incredibly low, actually. The new research is shocking how amazing it is.
Yeah, I think one of the things we've actually done is we've made women, divided this woman up into parts, right? She's not ever divided into parts. She's a person. She's got a little baby that she's growing. She's doing an amazing job growing a little baby in her uterus. Some have grown 5, some have grown 10, some have grown 1, and it's all happening in their unique life. But it's a transition through it's a transition through conception, pregnancy, labouring, giving birth to her baby, and then to breastfeed, or if she chooses other ways of feeding, that's fine too. And again, that depends on the unique woman. For example, I have worked with one beautiful woman in Victoria, in Melbourne, Victoria, who only had one breast that developed. The other glandular tissue didn't develop. She fed 4 babies for 2 years with one breast.
Women are amazing, and this is another moment where we can stand strong and say our bodies, they are magical, they know what they're doing. And if we were given more support, more encouragement, and more education, more access to real education that allows us to make informed decisions like this lady did, then we would be able to achieve our goals, whatever they may be. They're of course going to be different and unique per woman. And I think that's important to say, that we are unique. That's something that we do emphasize within the Thompson method.
Yeah, and it's listening to her, and it's learning to know what she knows about herself. It's us not telling her what to do, how to do it, because you might get this happen, or the baby might die, or the coercion.
Which is really shocked me that was said. I mean, within so many words, actually, unfortunately, within my birth, because baby Grace was measuring institutionally small, I'm going to say, because she was perfect for me, for my body, for what is normal for me. But compared to a graph, based on whatever graphic or measurement, which I'm sure can be helpful in some terms, but I made the decision that I was happy. Everything else for me was showing up positive. So I made the decision to keep going, and they were not happy, Dr. Robyn, that I was making this decision, and they made it clear that they were not happy about that. And
that's right. You don't know anything about yourself. You're not allowed to make decisions.
No,
right?
Exactly. And this is why I appreciate how women are so easily coerced, because it is scary standing on your own and standing strong and making these decisions when we're behaving that way as professionals.
And we stand over when we're talking to people. We don't sit down with them side by side, and not beyond the desk either, behind the desk, where there's that dominance. There's dominance all the time, standing over, sitting behind a desk. Pull up by the side and talk and have eye contact.
Yeah, they barely even look at you, because they're just reading your notes. They're just flicking and ticking. And I mean, I have met some wonderful midwives. I've met one very wonderful obstetrician during my journey this time round. But I must admit that overall it was very rushed, because of course they have a very busy job. They're under pressure. The governments are not funding the trusts enough. There are many, many reasons why we're in the position that we're in, as professionals and as pregnant women and new mums as well. But talking about the interventions, and we just went over there a couple of the reasons why sometimes intervention might be suggested or even necessary.
Of course.
When these interventions happen, going back to that cascade of intervention, 2 in 5 end in C-section. Sometimes maybe that's not the case. Those 2, it seems as though a lot may need other sort of assistance, like forceps birth, or it's linked to shoulder dystocia, and the few lucky women do end up having their wishes met, and they do end up birthing vaginally as they wish. Some even in the water, if they have the right birth plan and they stand strong. Many women are told that if they accept induction, that they're not allowed to birth in the water, because they need constant monitoring. But there is no law that states this.
You can monitor in the water, and women do rupture their membranes in the water spontaneously. So again, unless you've been a midwife for a long time and you've been privileged to be with these women, you're not learning in the system with the deepest respect as you are when you're with a woman in her own home. That's the best place a woman can be, and then have access to the system when she needs it. But again, when you're way out in the country areas, it's really hard when politicians start closing down the country services, or there's not the right staff or enough staff to be attending the country services either. And women are birthing on the side of the road. Now, that's not respect for the women that we have in our countries. It is not respect at all. And I get really frustrated as the old midwife who's had such a privileged career to see these things happening with women. And, you know, if we stop rupturing membranes, then we'll stop altering the hydraulic pressure around the baby. That hydraulic pressure there, unless the membranes, the forwarders rupture themselves, is there for a purpose. It's there to buffer the baby. It's there for the baby to drink during labour. Every time a baby drinks, the baby has the hiccups. You can tell the baby's drinking right through pregnancy. We talk about it, and the women say, oh, yes, that's happening. And so, again, the babies need to drink in labour. They're working too, and they do. And if the baby's head down, obviously the water's falling to the lowest level, and it might have a hind water leak. That's okay, because the pressure is building up as the uterus contracts and retracts, and the pressure around the baby's building up until the forewaters do decide to go, or sometimes when the baby's born in its sac.
Yeah,
and
it's called
born in the membranes.
cowl, isn't it? Educate me there,
Yeah,
Robyn.
and then and I've had a beautiful, beautiful couple of births where the babies have come to the surface from the water in their sac, and mum pops the membranes to say hello to her baby.
Yeah.
So again, we've taken away the experience that the old ones like us used to have to be able to mentor and pass on. I can go through so many tips, but our uterus is meant to contract and retract. It's meant to have hydraulic pressure to place the pressure on the baby's spine to descend, for the head to flex, for the cranial bones to mold, to come down, to have a presenting point or part that guides the way through the different angles of the pelvis, the different shapes of the pelvis. So from the oval shape to the round shape to the middle to the diamond shape to the outlet. And the baby negotiates all that if the mother is given the opportunity and we don't rush her. We have to say that every labour will be different. Yeah. Sometimes a woman, in my experience, would go into what we call the inert period. Yeah. Things would quieten down. Their labour didn't actually stop, but the hydraulic pressure was still there to buffer the baby when they did have.
This is spoken about quite commonly within hypnobirthing.
Can I finish? Can I finish?
Yes, sorry, go ahead.
Because it's really important.
You can see your passion coming out here, Robyn.
It's when the mother goes to sleep and her body relaxes, she relaxes, but she still makes the sound when the contraction is coming and when it goes. And we can still check the fetal heart rate. So it's not that we're not doing anything at all. We're quietly, gently, calmly doing it. And we are right there with her, beside her, and taking absolute notice of everything that's going on. So again, they're the things that we need to come back to, and medicine's there when they're needed. They do not have to be involved in all of the normal progress of labour. If things are progressing, it doesn't mean to say a woman has to labour and give birth within a certain time. She will do it under her own steam, her own effort, and in her own good time.
Yes, and that is something that
Sarah Wickham's book is brilliant. And
I was just going to quote that. Yes, and Her Own Good Time is a very good resource if you're looking and researching your options surrounding induction. But we'll pop some resources below in the comments, so do head down.
And Sarah's extremely skilled at talking about all the research that's available and putting it into context as well. She's very skilled at that. So
definitely takes out all of that medical jargon, and it is very easy to understand and to take on board. I highly recommend her page as well, which we'll pop below. But we often talk about the interventions during labour. Sometimes we talk about the interventions during pregnancy, but it's not very common that women hear of the interventions following giving birth. Now, for me, I had planned this birth with Grace, my home birth. It went beautifully, but I felt as though there was nothing I could do other than repeat the word no, no, no 1,000 times. Once my baby arrived safely into this world, that was it. It seemed they did somewhat respect my birth wishes, but once baby was here, they wanted that placenta out. They wanted me to have a wee. They wanted baby to feed straight away. There were so many things that I felt rushed within that I was confident enough to say, look, I'm good, but gosh, did I have to say it and repeat it so many times. And it was, not only was it boring, it was frustrating for all of us as a family here who knew things were going well. So my heart goes out to those first-time mums who are out there that haven't been informed about the third stage of labour, about those all-important 3 golden hours, especially if they want to breastfeed, and how so many things can interrupt that and really impact negatively the course of breastfeeding beyond that when they're discharged from hospital. Within that first breastfeed, which we do talk about quite a lot in the online education, under those 3 golden hours. So, you created that, Dr. Robyn, because you were seeing it yourself, weren't you?
Yeah. And that's what triggered my research, seeing so many women coming out of the hospital system with breastfeeding complications in relation to breastfeeding. Midwifery was something that I was skilled and loved, absolutely loved. And then, you know, the women taught me so much by being in their homes and out of the institution that I began to on a whole new learning curve. And phenomenal. I'm never ever 1 minute sorry that I took that time and enjoyed every single minute, including going interstate, including flying in an aeroplane to Japan to be there for my first grandson's birth at home. And yeah, so you know, it's I don't know. I feel so much for my colleagues now and the younger generation midwives coming through, the ones that are starting out now, because they're just not having that wonderful mentoring opportunity that we did have. I mean, there were firm times and there's times when you have to be on the alert, but certainly, you know, my thoughts are, don't touch the woman's body. You do not need to sweep her membranes. What do you mean by sweeping?
Yeah.
It's like
It's got such lovely language, isn't it? And actually here in the UK, a lot of trusts have a guideline that it's offered no matter what situation mum is in between 38 and 39 weeks, which considering it's just an estimation date, baby might not be ready. Exactly.
Keep your fingers out of her vagina, stop sweeping her. And you imagine if you blew a balloon up in somebody else's body, how they would feel if you did that and blew it up in a highly delicate, sensitive part of their body that's designed to give birth to a baby. And we put all these, and I've had one young woman crawling around the floor in the postnatal ward because she hadn't got to the labour ward yet, so they'd put her up there and screaming to get this thing out of her, and they would not take it out. They sent her to the labour ward instead. A young woman. Can you imagine the mental strain on her for that? And this is what makes me so passionate about what goes on, because not many people realise what goes on behind closed doors. It's very
and a lot of women don't realise, well, apologise for the negative language, but what they're getting themselves into when they step foot in the hospital. And that's why, and we were talking about this earlier, Dr. Robyn, that's why it's important to be fully prepared, not just for the plan that you have in mind, but for any outcome, for any situation during your pregnancy, labour and following birth. But most importantly for that birth. And that's why Dr. Robyn includes a template, a really helpful template within the online education, which is a birth plan and breastfeeding plan template. And it gives you some key things to consider and add to your own unique plan when you are having a hospital birth. But I also use this template as well as my own for my home birth. It's interesting to have in case your plan doesn't go to plan, and having the education behind you on, for example, what to do if you're separated from your baby, if baby's APGAR score is below 7. There is so much that you and our lovely midwife Rachel Austin discuss within those prenatal classes, and then in the module surrounding the 3 golden hours. There's so much to learn, there's so much to know, and there's so many informed decisions to be made that it will actually shock you how much control you can have. You can take back that control, and you can say no. I've learned that myself, thankfully, from our wonderful team of women that we work alongside and the women we see every day give birth. We are strong, we can say no, and with a smile on our face. No, thank you.
And we do not take babies off their mothers if their APGAR score is 7 or above. We should not even handle or touch a baby. If we're looking and skillful with our knowledge and our observations, we can look at a baby and see. And it's very, very important, unless there's a predicted problem that we think that might be appropriate to help with. And again, we don't ever say no, but we do say give every woman the chance that she needs. This is her baby, her body, her labour, her birth. And, you know, the stories that come out that are positive are the ones that haven't had the interventions, that are comfortable with what they're doing. And yes, they work hard. It's meant to be. That's why I suppose it was ever given the name labour, because it is hard yakka. It's hard work.
But it's beautiful in itself as well. And although women think that having a date, knowing the date that baby's going to come, might make it easier for them, actually a lot of women are reporting the pain associated with induction as well, because the contractions are forced on, they're sped up. And the Pitocin, is it called, Dr. Robyn?
Yeah, oxytocin infusion, yeah. And, you know, the oxytocin drugs, which contract the uterus harder and longer. And sometimes the women are telling the stories in the videos that I have, how they're pushing it up and they're actually pole driving the baby through the pelvis by increasing the rate. And these women have often screaming with what's going on, and no one is taking any notice of them. So again, there's the women who do it calmly, who do it gently, who do it quietly. There might be the woman who benefits from the oxytocin drip, intravenous, I should say. It's the oxytocin intravenous. She might benefit from that, as long as it's not pushed through by a piece of equipment that drives it through, and it's controlled gently and slowly by the midwife who's there and works with the woman under her steam, not the mechanical steam that goes on. The mechanics.
So that was a message for any of those watching who believe that the Thompson method does not support interventions, because that is completely false. We of course do, in the right setting, right environment, and with the right care.
Well, it affects the transition to breastfeeding as well. You know, all of these things affect the mother emotionally, psychologically, physically. And are we really focusing on that? Excuse me, I need a little drink.
That's the passion, that is. And a long day of work.
Are we really focusing on her? Are we doing what the policy says, the policyization, or are we doing the things that we should rethink? It's time to rethink. It's time to listen. It's time to observe carefully and be gentle and calm, and always, always to be respectful, always.
Beautifully said, as always. And after today, I hope that you guys have some questions. Let us know if you have any questions. Get in touch if you're pregnant, or maybe you've just had your baby, or you have an experience you'd like to share. Get in touch. We are continuing this series of the Isation syndrome with part 3 the week after next, and we are going to be talking about the lactationization of pregnancy, labour and birth, and how we believe that the resources available to most women are now outdated, and they need to be questioned. They need to be questioned, and we need to take a new approach to motherhood and to breastfeeding, and to labour as well. So, Dr. Robyn, is there anything you want to end with on this topic before we say goodbye to our lovely viewers?
No, just to those beautiful women out there, remember, this is your body. It's your transition through what you're doing. And if you need help, yes, of course. And if you have the right sort of help where you can choose your carer, that's even better, because that makes such a difference, because you're feeling confident with the person that you're with. And, you know, I have been with women that have, and I'm sure other midwives have been with women that have had more, but I've been with women that have had 6 babies, you know, over a long period of time. And, you know, just last week I had a call from a family that I was there for this young mother that's just had her first baby. I was there for her birth.
Wow.
And for the other 5, there were 5 siblings all together. And I'm so proud of that, you know, so proud of it. And obviously they're loving it too, because they're you know, the new generation's coming, and it's very
how lovely, that continuity of care. How wonderful. I bet there is so very few women in the world that get to experience that nowadays. What a pleasure. Well, thank you as always, Dr. Robyn Thompson, for your wisdom, your wonderfulness, and for your time. We know you're very busy, but
am I full on?
No, we love it. It's great to give our new viewers a little tidbit into your passion as well. And we like to discuss topics that are controversial, don't we? We like to keep each other on our toes. So if there's anything that you would like Dr. Robyn to be discussing over the course of the next year, do let us know. We are hoping to be starting a new podcast eventually as well. So do get in touch with us. What do you want to hear? What is important to you as a woman, as a breastfeeding mother, as a pregnant woman? Let us know. And thank you so much for anyone watching. Do join our free Facebook group to further familiarise yourself with Dr. Robyn and her methods, and take advantage at the moment of the 50% half price sale that has been extended, as well as our split payment option as well. Just take advantage so that you can be fully prepared for your birth and breastfeeding journey.
And happy mothering and happy breastfeeding to you, babe.
Yes, indeed. It's amazing and it's wonderful and it's all yours. So God bless everyone and take care. Thank you so much, Robyn. You're the best.
Take care. Take care. Thank you.